Shobha,
Ma'am,
just
record.
Shobha, just wait.
Ma'am, started.
Yeah.
A very good afternoon to everyone. A hearty welcome to Sankalp, the family planning webinar from FOGSI ICOG. At the outset, I must place before all of you my sincere gratitude and thanks to the President, Dr. Rishikesh Pai, the ICOG Chair, Dr. Lakshmi Srikhande, and the entire FOGSI office bearer team and ICOG office bearer team for the opportunity given to me as governing council member for Sankalp family planning webinar. This month we have chosen the subject of intrauterine contraception because we felt that it has long been amongst us from the beginning of the family planning program, but it is heavily underutilized. So I welcome the chairperson, Dr. Lakshmi Srikhande, to give her welcome address, and then we shall proceed.
Thank you. Thank you so much, Shobha. And I must tell everyone that this is your brainchild and you are doing a great job for this FOGSI ICOG Sankalp webinar on family planning. And it is so good that you have now taken it a topic wise, like oral, then IUCDs and all. So focused webinars will go a long way in educating and making aware our members about the different family planning methods. So I take this opportunity to welcome convener Dr. Shobha. I can see our vice chair Parag is here, Ashish Mukhopadhyay, all my governing council members, faculties, speakers, chairpersons, and all dear delegates. So welcome all. Happy learning, and I hand over back to Shobha for further proceedings.
I shall begin with the opening the first session and introducing the chairpersons thereof. I'll just share my screen. Give me a second for sharing my screen. Yeah. Okay, I should have opened the PPT first. So here we go, dear friends, welcome to FOGSI ICOG Sankalp webinar for family planning. And we have a very, important assemblance of really great teachers and of the faculty speakers as well. So it is now my duty to bring in the chairpersons for session 1. Well, this is a misplaced slide. This is about me. This is my thanks to Dr. Rishikesh Pai, the President FOGSI 22-23. And in fact, Sankalp webinar are very much in tune with his concept of Badlav. And we also look towards integrated care, just like the President is so vehemently propagating this year. Thank you, Dr. Pai. And then we have Dr. Lakshmi Srikhande, the medical director of Srikhande Fertility Clinic at Nagpur, but more importantly, our very dear chairperson of ICOG and so very dynamic. She'll be ably introduced by Dr. Anuradha Khanna in a minute. Thanks to Secretary General Dr. Madhuri Patel. We miss her presence today, but she has always wished me well, even as a chairperson, and she's very passionate for the service of family planning. So thank you, Madhuri. So here comes the chairpersons. Someone who is being known in the field of teaching so well by everybody and so much liked by all is Professor Anuradha Khanna. Madam is ex-head of HOD of Banaras Hindu University, Varanasi, but for us, she never becomes the ex. She's always feels like the head. Of course, she has headed the local society of Varanasi, OBGYN, and also president of SFM UP chapter, also of the Menopause Society there. And she has also held posts in the state chapter of ICOG, including being the president. Madam has organized several conferences and her teaching is very well known. So we welcome you, madam, to the Sankalp webinar. Thank you very much for taking time out. We know that your conference is just a week from now, but you have given us time. I am very grateful for that. And then we have someone whom we fondly call as Ashish Da, but we can also call him as Kishore Kumar of FOGSI.
Yes.
That is what we feel that he is. He's got a wonderful voice, but also a great human being, always keeping everybody happy and smiling. We are grateful to you for that. But at the core, he is a very tough postgraduate teacher, from what I can make out, principal now, and a professor and unit chief of CSS College, Kolkata. He has been the vice president FOGSI in 2016-17, and we look forward to very high posts from Ashish sir. Welcome Ashish sir to our webinar. So I now request the chairpersons to take forward the scientific session. So I will share the CV when you want me to.
No, I will share my PPT and first slide is the CV only.
That's great then.
Yeah.
Yes.
I will stop sharing. So
Yeah.
sorry,
I will like to see the CV of Dr. Lakshmi.
Yes. Can you see?
Yes, please.
Yeah.
Make it on the screen. Yeah. So it's a great pleasure for me to be here in this prestigious ICOG webinar. And this is arranged by Dr. Shobha Gudi. I am obliged that you invited me as a chair. And it's my great pleasure to invite for the talk Dr. Lakshmi Shikhande. She is very close to my heart. Of course, she is the chairperson of ICOG, a very, very well-known personality in all over India. And she has been National Corresponding Editor of Journal Jogi, National Corresponding Secretary of Association of Medical Women of India, founder, patron, and president of ISOPAB Vidarbha Chapter 19 to 21, chairperson of IMS Education Committee 21 to 23, president of Association of Medical Women Nagpur 21 to 24, senior vice president of FOGSI 2012, and president Menopause Society Nagpur 16 to 18, president of Nagpur Obs and Gynaecology Society. She is also medical director of Shikhande Fertility of Maharashtra. She is Nagpur Ratan Award awardee and received many awards. Received Nehru Yara Consortia Best Community Award for her work as a chairperson for HIV and AIDS in 2007 to 2009 as a FOGSI. Received appreciation letter from Maharashtra government to save the girl child. Delivered more than 18 orations, 450 guest lectures, publications 30 national and 11 international, and sensitized more than 2 lakhs and girls of adolescent. I've been in that program. So hereby I invite you, Dr. Lakshmi Shikhande, for your deliberation. Please.
Thank you. Thank you so much, dear Anuradha, for your kind words. And friends, today I am the opening batsman and I will be discussing LNG IUS beyond contraception. We all know that it is the gynecologist's best friend, I will call it. It is a long-acting reversible contraceptive. It releases the progesterone and the efficacy is similar to or even better than sterilization. But apart from its indication as contraception, it has many other indications as well. The first and foremost indication, which is heavy menstrual bleeding, also in dysmenorrhea, protection from endometrial hyperplasia. So let us see one by one these benefits in detail and how we can have beyond contraception the benefits of LNG IUS. For that, you have to just have a look at mechanism of action. Of course, the thickening of cervical mucus and inhibition of sperm motility is for the contraception effect. But when we are talking of its benefit beyond contraception, this is the mechanism of action which come into play. That is prevention of endometrial growth. As you all can see in this picture, that before LNG-IUS, the endometrial changes, and after LNG-IUS, the changes that occurs in the endometrium. So this is the first choice therapy for heavy menstrual bleeding. I know there are many myths, conceptions still in the mind of we doctors and care providers as well, but this LNG-IUS rapidly induces clinically and statistically significant long-term reductions in menstrual blood loss, which is paralleled by increase in hemoglobin and serum ferritin levels. The long-term management options for control and symptoms, and of course in quality of life, is definitely there with LNG-IUS in cases of heavy menstrual bleeding. So first, when we are talking of its role in heavy menstrual bleeding, we all should know what is heavy menstrual bleeding. First, you have to confirm from the FIGO tool that whether this is a subjective feeling of heavy menstrual loss or whether it is really objective and this lady is definitely having bleeding more than 80 ml per cycle, because then only you can label her as a case of heavy menstrual bleeding. And if she's really having suffering from HMB, then it has a negative effect on her quality of life, because it causes anemia and all the side effects of anemia in terms of fatigue, irritability, and everything. So you can see that HMB, it definitely affects the woman's life. 4 out of 5 women who suffer from heavy menstrual bleeding, they say that it affects their personal and professional life. So these are the statistics that 82% women, they have problems. If they are suffering from HMB, they have problem with relationships. 80% have problems with performance at work, and 60% they have problems with the attendance at work or at school. The etiology, we all are making aware our FOGSI members that whenever you are dealing with a case of abnormal uterine bleeding or heavy menstrual bleeding, you have to make it a habit of using palm coin classification in your day-to-day practice. It is very simple to implement. Once we make it a habit, it will become a routine for all of you. So once you confirm that this lady is suffering from heavy menstrual bleeding, then you have to assess how much this is having a problem and how it is affecting her quality of life. For evaluation, of course, we always start with the medical history. You have to take this history in detail. You have to conduct the physical examination. You have to make it a habit of fitting that HMB or cause of AUB in the palm coin classification. You have to treat her anemia and provide reassurance and offer treatment. So this is the treatment algorithm for heavy menstrual bleeding. And as you all can see, that when it comes to medical management of palm coin classification, then LNG-IUS is the first line of treatment for medical management of heavy menstrual bleeding. So these are the key considerations in heavy menstrual bleeding management, that you have to consider all these factors before you start treating her with LNG-IUS or any other hormonal contraception. Even though I am saying that it is the first line treatment, of course, individualized therapy, and it has to be customized according to that woman's needs. That is the key to management of heavy menstrual bleeding. So first line is LNG-IUS, second line is tranexamic acid, NSAIDs, combined OC pills, and then the other hormonal medications which come into play. Now just let's look at the statistics, how LNG-IUS is superior to all the other methods. This is the first study where there was significant reduction in mean blood loss and there was increase in serum hemoglobin levels. So according to this, LNG-IUS significantly reduces menstrual blood loss from as early as 3 months after its placement and is associated with a significant increase in levels of serum hemoglobin and ferritin. When LNG-IUS is compared with other medical modalities for heavy menstrual bleeding, it is found to be more effective than tranexamic acid, mefenamic acid, combined estrogen progesterone, or progesterone alone in reducing the effect of heavy menstrual bleeding on women's daily life. LNG-IUS is also found to be more effective than flurbiproxine, tranexamic acid, and mefenamic acid, again in these studies in reducing menstrual blood loss in those women who are suffering from heavy menstrual bleeding. When it was compared with the role of medroxyprogesterone acetate, it was found that LNG-IUS is significantly more effective than MPA at reducing menstrual blood loss in those women who are having heavy menstrual bleeding, and this has a higher likelihood of treatment success. When LNG-IUS was compared with low-dose OC pills for the treatment of HMB, it was found that reduction in menstrual blood loss was significantly more in LNG-IUS group as compared to the COC group. When it was compared with endometrial ablation for heavy menstrual bleeding, LNG-IUS was found to be equally effective as endometrial ablation in reducing menstrual blood loss up to 2 years after treatment or after its placement. Can LNG-IUS be an alternative to hysterectomy for heavy menstrual bleeding? Just have a look at all these comparison of all these parameters, and both LNG-IUS and hysterectomy, they are associated with significant improvement in the quality of life over 5 years of follow-up. But when it comes to the emotional role, LNG-IUS stands much above as compared to the hysterectomy. Because women, though they are both equally satisfied with LNG-IUS and hysterectomy, the total healthcare cost when it is compared, it is found to be 40% lower in LNG-IUS group. Can LNG-IUS be used in adenomyosis? Yes, according to these open randomized observational studies, the efficacy of LNG-IUS is definitely there in cases of adenomyosis, and it seems to be a viable and effective treatment option for women who are above 35 years of age, and there is a high rate of patient satisfaction. Even in cases of fibroids related menorrhagia and idiopathic heavy menstrual bleeding, LNG-IUS significantly reduces mean uterine volume in those women who are having menorrhagia, and it definitely reduces the menstrual blood loss in cases of uterine fibroids. In cases of endometrial hyperplasia, we all know that now LNG-IUS is the first treatment of choice in endometrial hyperplasia without atypia. So it causes regression of this hyperplasia, and it is a very effective therapy in endometrial hyperplasia without atypia. LNG-IUS also has a role in cases of ovulatory dysfunction, and it is found to be superior to norethistron in those women who were having AUB-O, that is according to the Palm-Coin classification. According to Palm-Coin, there is a AUB-N category, and here also a randomized clinical trial when it was conducted and LNG-IUS versus low-dose COC was compared, they found that LNG-IUS is more effective for idiopathic amenorrhagia as compared to the combined oral contraceptive pills. So now when I'm saying that it has got so many benefits and it really scores over other medical management of heavy menstrual bleeding, one should know the adverse effects as well. The adverse effects reported are very minimal. They can be in terms of menstrual problems, lower abdominal pain, and other minor side effects, because after all, it's a progesterone containing device and it releases progesterone daily. these adverse effects, they decrease markedly over time. The other side effects such as lower abdominal pain, acne, headaches, they are seen only in 2 to 3% of women, and they do not cause a major concern among the women. But provided you counsel her. The other benefit apart from menorrhagia is in cases of dysmenorrhea, because LNG-IUS significantly relieves women from dysmenorrhea from as early as 3 months after placement. Beyond contraception, it also has a role in menopausal hormone replacement therapy. But whenever you are using LNG IUS, that to beyond contraception, you have to counsel her for benefit versus risk, and you have to counsel her for her expectations of bleeding pattern once you place this LNG IUS inside the uterus. So counseling has to be in a systematic manner. It has to be a thoroughly counseled woman, and it has to be documented counseling. So these are the intra recommendations for pre-placement counseling. And when we say intra, what does it mean? It is a base group of independent physicians with an expert interest in intrauterine contraception. So these are the pre-placement counseling checklist which you have to take care of, and you have to counsel her accordingly. So I will just take 2 to 3 minutes more and tell you in detail about what you should do pre-placement, what is the troubleshooting when she comes to you with irregular bleeding after placement, and what are the post-placement considerations. So when you can insert these LNG IUS, it can be inserted at any point in the menstrual cycle, provided the woman has not had unprotected sex since her last menses, and she agrees to continue with her current method of contraception until after IUC placement. However, we all know that procedure is slightly easy when it is inserted during or at the end of menses, when cervix is slightly soft and dilated. Pre-placement pap screening is not evidence-based, and absence of the pap smear report should not be a barrier in inserting LNG IUS whenever it is indicated. It can be inserted without any kind of cervical priming in majority of the women, but in case of difficulty, you can take help of misoprostol for making your job easier. So you have to do vaginal administration of misoprostol 4 to 8 hours before you insert the LNG IUS. And oral analgesia usually is not required, but if patient is very apprehensive, you can definitely give her pre-placement oral analgesia, that is ibuprofen, 400 to 600 milligram or 1000 milligram of paracetamol 1 to 2 hours before placement of your LNG IUS. Should you do uterine sounding before placement? Usually it is not required, but of course what you require is good visualization and good lighting is required. In very minimum number of women, you might have to take help of paracervical block. If they are too apprehensive, they are just not allowing, and you feel that LNG IUS is best for her, and she has also consented for its placement, then of course you have to use your verbal anesthesia, distraction techniques. But apart from that, if it is too apprehensive, you can give paracervical block and you can insert the LNG IUS. Now, after its placement, cutting of the thread, it has to be, you have to cut the thread approximately 2.5 centimeter in length, so that it does not cause any discomfort to the male partner during intercourse. And by keeping this adequate length, she can feel and she can be assured that device is in place. Immediate post-placement, you have to be very alert for the possibility of vasovagal effect, which can occur during or after the placement procedure. And post-placement analgesia is usually not required in most of the cases. Routine use of ultrasound to check the correct positioning of the device in the uterus is not necessary, provided that the uterus was sounded before you did your LNG IUS insertion. Monthly string checkups to call her for monthly checkups are also unnecessary. Now let's come to the post-placement troubleshooting, because she has come to you for management of heavy menstrual bleeding, and after LNG IUS she should know what is to be expected as far as bleeding pattern is concerned. So the frequency of common side effects such as spotting increases in initial 0 to 3 months, and this decreases gradually over the period of time. And this should be very clearly told to the patient so that she is mentally prepared and she knows that this is a minor side effect of LNG IUS insertion. The frequency of spotting is high initially and it decreases gradually. Percentage of women presenting with oligo and amenorrhea increases, and 50% women they present with amenorrhea or oligomenorrhea over a period of 2 years. The adverse effects in initial 0 to 3 months, when you are inserting it for the menstrual problems, you have to explain to her that she might have lower abdominal pain, which also decreases gradually. So once she is mentally prepared, she will accept this spotting, this lower abdominal pain. So before placement of LNG IUS, you have to counsel her on the bleeding pattern and the pain in abdomen which she has to expect. In case of persistent abdominal or pelvic pain, you should look for displacement of LNG IUS, or you have to exclude other pathology by clinical examination and appropriate evaluations. Usually, LNG IUS does not increase the risk of pelvic infection, but even if it develops, it is mild to moderate. Therefore, it is very essential that its placement should be done under all strict aseptic precautions. If the infection is severe, it is advised that you remove this LNG IUS and give her appropriate antibiotic regimen. Of course, when you are inserting LNG IUS, you have to tell her about the progestational side effects as well, so that she is mentally prepared. Now, whenever we talk of progesterone, every woman is concerned of weight gain, because they have read on Google that when you use any kind of hormonal thing, it causes increase in weight gain. So there is an average of 4 plus minus 0.9 kgs weight gain over the period of 10 years in the LNG IUS users. It is not significant between the users of LNG IUS and copper IUD. So friends, whenever you are inserting LNG IUS, this concern should also be addressed, that there is no evidence that weight increase observed in women using LNG IUS that differs from the weight gain associated with other hormonal use. So when it comes to safety related clinical outcomes, LNG IUS has got many benefits. It appears to have no clinically adverse side effects on bone mineral density, cardiovascular risk markers, metabolic parameters, vaginal flora, and cervical cytology. In addition, LNG IUS appears to have no association with an increased risk of breast cancer. This concern should also be addressed when you are inserting LNG IUS, and they should have a neutral effect on sexual dysfunction. So LNG IUS per se does not affect her sexual life also. So this is the Indian expert group recommendations. The key factors for counseling the patients when you are using LNG IUS for menorrhagia. First and foremost, you have to see to it that it is suitable for this particular woman. Then what are the other preferred options? Are there any contraindications? And you have to also see to it the acceptability part of LNG IUS as well. So when you address all these three options, that is suitability, her preferred options and acceptability options, you can go ahead and place the LNG IUS because it has got much more safety and more than 90% continuity rate after 1 year with LNG IUS is there, provided you counsel her well. So to summarize, clinically, heavy menstrual bleeding, we all know its definition. We have to do detailed medical history taking, clinical examination, relevant investigations. LNG IUS significantly reduces menstrual blood loss from as early as 3 months after placement. It is more effective than tranexamic acid, mefenamic acid, combined estrogen progesterone or progesterone alone over 2 years in reducing the effect of HMB on women's daily life. It is also effective in improving conditions. Specifically, quality of life has definitely improved and rates of surgical intervention is significantly reduced. Compared with women who are using conventional medical treatment, women using the LNG IUS for HMB, they have a higher satisfaction rate. And based on the recommendations from global and Indian guidelines, LNG IUS is the treatment of choice for idiopathic HMB as well as for selected patients with HMB due to underlying pathology, that is uterine fibroids and adenomyosis. So friends, LNG IUS has got definitely many advantages beyond contraceptions. It is satisfaction rate is very high and the side effects are very minimal. So thank you, friends. Thank you so much for your patient hearing.
Thank you, Lakshmi. Thank you very much. I haven't heard another more exhaustive but more lucid presentations on LNG IUS with the non-contraceptive benefits. It's really a wonderful presentation. She has covered all aspects of LNG IUS, and as I could see in my current practice, the usage of LNG IUS has increased over 50% in recent years, and most of the gynecologists have accepted this. And the old myth that was there associated with the intrauterine devices is gradually going away. So that's a good sign. And thank you very much, Lakshmi, for highlighting all these positive points. And HMB actually is a condition which is quite frequent, quite common, but one note of caution, because many patients do not, or rather cannot estimate properly the amount of blood loss they're having. And that's why she correctly said that the FIGO guidelines must be followed. So with that, I think I thank profusely Dr. Lakshmi Srikhande on such a nice presentation on LNG IUS. And she wanted some questions. Well, here is one of them, that a patient has a history of previous 3 LSCS. Is LNG IUS contraindicated? What is your take, Dr. Lakshmi?
LNG IUS per se 3 LSCS is not a contraindication, provided, I mean, you can insert it easily. I will advise, if you feel that it is the treatment of choice, patient also agrees, then call her on day 2 or day 3 of the periods, do a uterine sounding and try to insert it. But in case it is very difficult, then you have to think of other options. But in majority of cases, even after 2 or 3 LSCS, we all are used to inserting the copper Ts, and Mirena, believe me, it is much more easier than copper T insertion. So I mean, Ashish, I will only say that 3 cesarean per se is not a contraindication.
Absolutely, I agree fully.
Can I?
And
I would like to
Yes.
add something.
Nothing
Very
to
good,
do. Dr. Pushpa, yes.
very good talk. Excellent talk, Dr. Lakshmi. About this giving misoprostol. I have this habit of giving misoprostol just few minutes prior to any procedure which requires cervical dilatation. So in such cases, especially with previously scarred uterus or undilated cervix,
Correct.
they can give just orally. Patient need not have to wait for 4 to 6 hours. If we give it orally, the onset of action is fastest. Within 8 minutes, the cervix becomes soft. Can very well give
Thank
it
you, Dr.
orally.
Pushpa, those inputs, and here
Should
is
I
your
comment something?
Yes, Dr. Anuradha, yes.
Okay. So a big congratulations, Dr. Lakshmi, for a wonderful talk. Regarding HMB, we are seeing this palm-coin classification, but sometimes there is underlying infection. We should not forget about genital tuberculosis also. And this is also getting very prevalent, especially East Uttar Pradesh area. So I will like to see that whenever after choosing it, we must see in detail, there should not be any infection. And also we have to be very cautious regarding antibiotics. If patient is on any antibiotic like amoxicillin, clavulanic acid, cephalosporin group, doxycycline, they should not be given along with this LNG IUCD. They are contraindicated. That will decrease the efficacy. And regarding the emotional stability, you have wonderfully explained that women must be stable. And as for the checklist of copper T, there is also a checklist of LNG
That
in
is
which
what I told
she
you.
should not have a depression. If she is a case of depression or she is having progesterone effect already very much, like oily skin or fatty liver. So the things where progesterone is not indicated, rather contraindicated, we should not use this thing. And if she has got a history of breast cancer, ovarian cancers, then also it is not advised to have it. And breast examination is also a must, though pap smear is optional, may not be done, but it is very important. And if she develops hypertension or breathlessness or history of MI in the family, then also it is to be given with the very much caution. And regarding misoprostol, yes, it is good to use it, but the expulsion rate will also be high if you have inserted it after some time. But if you wait for 2 hours more than that, and then you insert, then the effect of misoprostol will be gone and well accepted, because if it remains for a longer time, misoprostol has got a role of contraction and then expelling the device, which will be not good for both the doctor and the patient. And this is very effective as a contraception for 5 years, but it can be extended to 7 years for HMB use. And if it is a submucous fibroid, then it should not be used. It is better to have for intramural or HMB causing other types. Thank you so much for a wonderful talk.
Thank you, Dr. Anuradha. Her talk was not on contraception. Perhaps that is the reason why she has omitted some of the discussions. Also,
Yeah.
the time was
No,
limited.
Ashish, it is very good because general contraindication, because after all, it's a progesterone, I said. It
Yeah,
releases
Yes.
progesterone. So before inserting, you have to be very sure that you rule out all the contraindications
Yes.
for progesterone in
Checklist is
that
very,
particular
very
human.
important.
So very well said, Dr. Anuradha. It has to be,
Yeah.
I mean, that checklist has to be checked
it has to be there.
that
Yes.
there are no contraindications.
Nowadays, everything should come with a checklist.
Yes, we
Now,
are.
it is
Because
my pleasure to
we
invite.
have to spend a lot time for it,
Yeah,
at least 5-10 minutes for both history and examination.
correct.
And then only if we will insert, it is very, very well accepted. I love this
Absolutely.
LNG IUCD.
Absolutely. Thank you, Dr. Anuradha. And now let us move to the another spectrum of copper IUCD. And for that, I would like to invite Dr. Pushpa Jungare. Could I have her CV slide, please, if possible? And her topic is new role for copper IUCD, post-abortion
Pushpa,
and emergency contraception.
just a moment, I'll share. Because I thought that,
Dr. Pushpa is.
yeah, can you
professor
see
and-
her, can you see here?
I can,
Just a
no,
minute.
पुष्पा का CV नहीं दिख रहा है.
Okay, just a minute, I've gone ahead.
हाँ, कोई बात
नहीं है ना?
We will wait.
Here, this is the CV.
no.
नहीं,
This
नहीं,
is
this is
Dr.
not. This
Sujata's.
is,
when you don't get any CV, we say she needs no introduction.
yeah, this is Pushpa. Correct,
Yeah,
correct,
this is
correct.
Dr. Pushpa.
Yes, this
Yes,
is.
she's a professor and HOD of OBGYN of PDMMC Amravati. She's a member of UG and PG Board of Studies of Surgery and Allied Subjects, MUHS. First visiting professor sent by FOGSI to Cuttack Medical College, Odisha, SCB Medical College, she means. Faculty in many national, state and zonal conferences. UG and PG examiner at various universities in India. Past president of Amravati OBGYN Society. She was the organizing secretary state conference of EMOGS in 2005 and organizing chairperson for EMOGS 2020 at Amravati. She has many awards and achievements and lots of publications. So if I go through the entire thing, it will be longer than her presentation. So I will refrain myself and invite her to present
Yes, sir, please.
on a very important topic, that is post-abortion and emergency contraception, two very neglected topics, and the use of copper ICD, where it is highly recommended. We welcome Dr. Pushpa Jungale.
Good evening. At the outset, I would like to thank Dr. Shobha and Dr. Lakshmi, it being a part of ICOG, for giving me this opportunity to present my talk. Should I start screening my?
Yeah, please, you can
sharing my
share your
screen?
screen.
I am not able to minimize my.
Have you opened the presentation on your desktop?
No, it is not visible
No.
actually.
No, your screen is visible, but first you need to stop share, then open your presentation on the desktop.
Okay.
Open it, but
So I'll have to stop share first.
first you stop
Right,
share.
right, yes.
Then go back to your screen. You minimize this. You minimize the webinar screen. Go to your desktop screen, open your presentation, but don't make it full screen as yet.
Okay.
Keep it minimized and then share your screen and make it full screen. Yeah. You opened the presentation in your screen?
Just few seconds. Yes, now I have opened it.
Yeah, so now you come back to the webinar screen.
And should I minimize my
Yeah,
presentation
you
now?
should minimize.
First?
Yes, you should minimize it. Keep it open, but minimize it. Come to this screen. And from here, you share the screen.
Right.
Yeah, we can see your screen. Yeah,
Yes.
now you make it full screen. What is that called? Slideshow.
Okay.
Yes, yes, yes. Please go ahead.
Yes, now it is visible. Go ahead, please.
Yes. So I'll be talking about the new role of copper IUCD. Now we all know the conventional use of copper IUCD as contraceptive or interceptive device. But recently the scope of its use in postpartum and post-abortion contraceptive, it has researched in a big way, and that is so because of its number of advantages. The use of IUCD as an emergency contraception, it also needs to be promoted due to its added benefits. Now, what is this post-abortion IUCD? That is, whenever we are managing a patient for abortion. So we can, at that time, we can counsel her that because she has come for medical termination of pregnancy and she is not interested in continuing her pregnancy. So that is a good time to counsel her. So post-abortion family planning is the initiation and use of family planning method during the management of abortion, or before she returns, before the fertility returns after the abortion. Now, WHO recommends spacing of at least 6 months between abortion and next pregnancy. So therefore, providing family planning services as a part of post-abortion care, it can improve the contraceptive acceptance and help break the cycle of repeated unwanted pregnancies. Recent evidence has shown that post-abortion contraception should ensure maximum effectiveness in preventing a repeat unintended pregnancy and possibly a repeat safe or unsafe abortion. So counseling it is necessary. Every woman must be counseled regarding the family planning options when she is admitted for induced abortion of undesired pregnancy, or even after spontaneous abortion. A woman is offered choice on contraceptive methods available, and she should receive adequate pre-abortion counseling, and she should give informed consent for that. We have to screen the eligibility of that woman for IUCD, and contraindication should be ruled out. She should be given the option of post-abortion IUCD with respect to its advantages, limitations, effectiveness, and side effects related to this device. There should not be any complications of the abortion, like infection or injury requiring further treatment. So in such cases, it is better not to give simultaneous IUCD or even LNG insertion. Timing of post-abortion IUCD insertion. Post-evacuation carried out after MTP, that is, as soon as we carry out suction evacuation or manual vacuum aspiration, we can introduce copper T, or at least within 48 hours after spontaneous or induced abortion. If there is lapse of 48 hours, then it is better to wait for a longer period. It can be inserted as soon as the expulsion has been confirmed in cases of medical abortion. That is, even in medical abortion, that is medically managed abortions, when we give mifepristol and misoprostol, even after that, we can introduce, making it sure that the abortion is complete and all the products there expelled out. Or later on, when she comes for follow-up, we can definitely use it 3 to 4 weeks in her next follow-up visit. It is important to clinically assess the patient and screen the client for post-abortion IUCD. The first assessment is a review of women's general, medical, reproductive, and contraceptive and obstetric history, and eligibility for method along with pre-procedure assessment. And then the second assessment is done immediately prior to insertion to rule out current genital tract infection, risk of infection, or hemorrhage and genital tract injury. So when we have completed the procedure of abortion, we should reassess the patient whether she is suitable for this IUCD insertion at that time or not. This patient's required follow-up, the woman should report immediately if she suffers from excessive bleeding per vagina or pain in abdomen, persistent nausea and or vomiting or fever. Actually, this is the way we advise follow-up in any patient who undergoes suction evacuation or MBA. So the follow-up protocol remains same. It is not because we have introduced IUCD that she is going to have these complications, but as such, because she has undergone MTP, she can have any of this. So she should be assessed regarding this. And during this follow-up, we should assess her physical condition, ruling out continuation of pregnancy, presence of infection, and incomplete abortion, or if at all there is problem related to the IUCD, we should be able to diagnose it and then give her proper advice. For routine follow-up of IUCD after 1 month, that is after the follow-up following abortion, preferably after next menstrual period. This is the time when any patient, whether we introduce it after abortion or after menstruation, interval insertion, it is the time, that is the next menstrual period, that she's likely to expel it out if at all there is chance of expulsion. So preferably after her next menstrual bleeding, she should be followed up. Follow-up care and management of problems of IUCD, of course, they will be same as that of interval IUCD. Now, why this post-abortion IUCD is advised? In fact, whenever a patient comes to us for MTP, that means she has opted for termination of the undesired or unwanted pregnancy. So naturally, she requires counseling regarding not to become pregnant again as long as she does not desire. So this is the very proper time to counsel her, because it is very convenient and it saves time of additional visit as the patient is already hospitalized for evacuation or MTP. Then patient and relatives, they can be motivated better because at this time they are more receptive. sometimes we notice that following second trimester abortion, the patient, when they are admitted, they are very much willing to have family planning operation, tubectomy, or IUCD insertion, or any other method of contraception. But as soon as they abort, they might run away without even information. So they are better counsel, and they should be advised that this is the best time that we can introduce IUCD. Another advantage is there is reduced perception of initial side effects of bleeding and cramping, which might be there because of IUCD, because this might be taken as normal post-abortion changes. And that is why when we introduce interval IUCD, we call them post-menstrually, because whatever bleeding is there remaining, it might be considered that it is continuation of menstruation. Similarly, if she has any cramping or bleeding, she might consider it as the problem related with evacuation. We need to take special precautions for post-abortion IUCD as compared to when we introduce in regularly menstruating women. So after first trimester abortion by suction evacuation, the size of the uterus can be assessed with the help of suction cannula that was last inserted. We never introduce uterine sound because gravid uterus, although now it is empty, it still remains soft, and we have to be very gentle in handling this. So it is better that we assess the size of the empty uterus with the help of the suction cannula that we have inserted last after emptying of the uterus. Even after second trimester abortion, as I've said, we can introduce IUCD. The technique of IUCD insertion, it will be similar to that of postpartum IUCD insertion. That is, we can take help of ring forceps or sponge holding forceps. Special IUCD insertion forceps are available, but with this smaller uterus as compared to full-term termination of pregnancy after delivery, the uteruses are smaller and cervix may not be that much dilated. But definitely ring forceps or sponge holding forceps we can introduce. And we can make help of these instruments to introduce IUCD. After medical abortion, the technique is same as that with interval IUCD insertion, though the uterine sound should be introduced very gently and very slowly and in proper direction. Otherwise, the uterus being soft, it can perforate. So that was regarding post-abortion IUCD. Another use of IUCD that needs to be promoted more and more is IUCD as an emergency contraceptive. Now, what is emergency contraception? Emergency contraception refers to methods of contraception that can be used to prevent pregnancy after sexual intercourse. And these are recommended for use within 5 days after coitus, but are more effective the sooner they are used after the act of intercourse. The sooner the better. Emergency contraception can be used in following situations: either unprotected intercourse, concerns of the patient like there is possibility of contraceptive failure, that is breakage of condom, or the slippage of condom, or if the patient feels that whatever method she was using, it has failed, or incorrect use of contraceptives, and sexual assault with without contraception coverage. This I'll come to it later on again about IUCD. Emergency contraception can prevent up to over 95% of pregnancies when administered within 5 days of intercourse. A copper IUCD is more effective form of emergency contraception available. Why? Because the most important is the patient can continue as ongoing contraception. How does it prevent pregnancy? The copper-bearing IUCD, it prevents fertilization by causing chemical change in sperm and egg before they meet. If at all fertilization has already taken place, and if the patient has indulgent coitus after that period, it will even prevent an implantation, because we know the role of IUCD as an interceptive device. That is, although fertilization might have taken place, even that is prevented by IUCD. But in case of emergency contraception, if that period is over and patient has, she might have already had a fertilized ovum, then this IUCD insertion anytime within 5 days, it is going to prevent implantation and it is going to prevent pregnancy. Eligibility criteria, it is For general use of copper IUCD, it is going to apply for the use of copper IUCD for emergency purposes also. So women with any infection, pelvic infection, puerperal sepsis, unexplained vaginal bleeding, puerperal means post-abortion sepsis, unexplained vaginal, any type of sepsis when she had indulgent coitus, unexplained vaginal bleeding, cervical cancer, or severe thrombocytopenia, they should not use copper-containing IUCD as an emergency contraceptive. A copper-bearing IUCD should not be inserted as emergency contraception following sexual assault, as the women may be at risk of sexually transmitted infections such as chlamydia and gonorrhea. So other methods of emergency contraception, they should be advised in patients who have been subjected to sexual assault and having fear of pregnancy. So here it is one place where it is not indicated. Now, what are the advantages of IUCD as an emergency contraceptive? If a copper IUCD is used for emergency contraception, no additional contraceptive protection is needed. This method particularly is appropriate for women who like to start using a highly effective, long-acting and reversible contraceptive method. So it can be placed and she can use it as an ongoing contraceptive method. When inserted within 120 hours of unprotected intercourse, a copper-bearing IUCD is more than 99% effective in preventing pregnancy. This is the most effective form of emergency contraception available. Once inserted, women can continue to use this IUCD as an ongoing method of contraception. I'm stressing this point more and more because that is the biggest advantage of IUCD as emergency contraception. It is quite safe. The copper-bearing IUD is a safe form of emergency contraception. It is estimated there may be less than 2 cases of PID in 1,000 users, as per Family Planning Global Handbook. The risk of expulsion or perforation are very low. So I thank you for your patient listening. Thank you.
Thank you so much, Dr. Pushpa. It was an excellent presentation divided in 2 parts. One is the post-abortion and another is emergency contraception. I believe that copper T has been underutilized for both the conditions, both the occasions, and it's high time that we should promote them. Particularly the contraceptive benefit of copper IUCD is extremely well accepted and reliable. The only thing is that you should exclude the chances of infection, running infection. And but there was once upon a time we had a misconception that IUCD increases the chance of infection, which has been disproved. Since 2014, there are many studies which have proved that copper IUCD as such doesn't increase the chance of pelvic infection. So I think it also doesn't promote the ectopic pregnancy. So that is also, there are 2 important things that we must remember, and we should promote this because this is one contraceptive which is going to be continuing with the pregnancy, with the patient, and therefore it is extremely beneficial for the patient. Thank you very much, Dr. Pushpa. I can't see any other question in the chat box.
Correct. Questions are not there, but a lot of appreciation that it is a good topic and it should be promoted as easy. Thank you, Dr. Ashwini Bhalerao, for agreeing with us. And Ashishta, Anuradha ma'am or Ashishta.
I think appreciations are more important because both the speakers were extremely good and they have done full justice to the topic. So appreciation to banta hai.
एक point of discussion लाना चाहूंगी मैं. One point of discussion is when it is a second trimester, either medical or a completion evacuation. Also, a post-abortal IUCD can be inserted, Dr. Pushpa, because I feel that is one clarity that we need to give.
Yes, it can be inserted. I had mentioned earlier. In second trimester abortion, it is as good as postpartum IUCD insertion, post-placental. So in similar way, we can introduce. And post-medical abortion also, once we have confirmed, we may take help of ultrasonography to make it sure that the uterus is completely empty. Then
one very important message that you have given, Dr. Pushpa, is the insertion is ideal before 48 hours of the abortion, because After that, the chances of expulsion, infection, etc., they increase, and therefore then
It
we
is
have to
an
wait for a
immediate
longer period of
inception.
time, 4 weeks. It's a very good
Yes.
message that we should have, and I think that the immediate insertion of a post-abortion copperty is very, very important. Dr.
One more,
Anuradha,
correct.
Dr.
One more
Anuradha,
input here is when it is LARC method which follows abortion, it has been found that the requests for repeat abortions are less in this population than those women who opt for short-acting methods. So LARC methods are very suitable for women who are seeking abortion care. They can be counseled and it can be done. The other thing is the
Doctor,
checklist. Yeah, fine. Yeah. Yes, ma'am.
yeah, just I wanted to say one thing, that post-abortion, we must be very, very sure about the thing. There should not be any RPOC, because if it is not done by a senior person, junior persons, there may be content left. And if they are doing this postpartum insertion, then complication rate will be very high, because those facilities are nowadays, ultrasound is very much available in periphery also, or tertiary centers also. So if it has been rechecked that there is no RPOC, whether it is a first trimester or second trimester, then it is worth applying it. And if it is not being sure, then in such cases, I will like to avoid post-abortion insertion. And also, of course, those who are having infection, then also the checklist list already we have discussed, that is and must, then only it will be successful. Otherwise, a wrong message will be conveyed and it will not be of good health. Thank you. Thank you very much, Dr. Pushpa, for your such commendable job.
Thank you.
so we'd like to return the microphone to Dr. Shobha Goody, because both the speakers have done full justice to the topic, and I hope that she's happy. Dr. Shobha.
Sir, आप मेरे को हमेशा दे ही देते हैं microphone. Earlier also I took it without your permission. So sorry for that. So thank you, sir. Thank both of you for
Thank
your
you,
valuable
madam.
presence.
Thank
and
you,
your
Dr.
inputs.
Shobha.
Yes,
Thank
yes, ma'am. The one thing is, am I audible better? My volume is
Absolutely,
low actually.
absolutely.
Yeah.
Loud and clear, madam.
So the thing is, we shall go on to the next session very quickly, because
Sure,
but if the chairpersons can be there, because we have a couple of very interesting talks on publications, and since it's a ICOG forum, research and publication in the field of family planning needs to be so much cherished. I can't tell you, because this is something that is not easy to perform. So I will invite the chairperson. Unfortunately, Dr. Geeta Balsarkar is unable to be here. She has got an NMC inspection. But we have our past Vice President of FOGSI, Dr. Sujata Mishra, with us. And I will just share her CV and I will introduce her. Thank you, Sujata Madam, for being with us here with us today. In fact,
thank you.
Yeah. And
This
then
is Dr. Pushpa's.
Yeah, there are some questions in the chat box which are still unanswered. I promise to the audience that we will answer them after this, because I really feel that we'll get on with the scientific and then have discussion. So Dr. Sujata Mishra is Professor and Unit Head, Department of OB-GYN and Superintendent, PGI MER, Bhubaneswar, Odisha. Very, very popular postgraduate teacher, very inspirational Vice President she was. Very fond of her. She has been secretary also for Odisha Society, the state chapter. And of course, she was chairperson of Medical Disorders in Pregnancy Committee of FOGSI 2009 to 2012. And she holds many important posts, including being an academic counselor at IGNOU and a principal investigator in the WHO champion trial, action trials, etc. And I think she is very apt for this session with her rich background of research and publication. Thank you, Dr. Sujata Mishra. The other chairperson was Dr. Geeta Balsarkar, the editor-in-chief for Jogi, but I am sorry that she was not able to make it today. So we are missing you, Dr. Geeta. And with your blessings, we are taking this forward. So I will now end this slideshow and I'll request I will in fact, share the screen for the CV of the next speaker, Dr. Sharad Iyengar, and I will request Dr. Sujata to introduce him, and then I will stop the screen share and she can give any other words that she wants. Yeah. Yeah. Dr. Sujata.
Shobha, thank you
Yeah.
so much for those kind words of introduction. I'm sorry I lost the network for some time.
Yeah.
So shall we go ahead and talk about our brilliant speaker, Dr. Sharad Iyengar?
Yes, please.
Yeah?
Yes, please.
Yeah.
Yes.
So
Please.
thank you so much. So there are a host of things which all can see on the slide. Being a health professional and pediatrician involved in reproductive and child health research and community interventions at PGIMER Chandigarh. And he was also with the UN Population Fund in Shimla, Delhi. He's the co-chair Gender and Rights and member Scientific Technical Advisory Group. I really don't think we need to go through the entire, so many laurels to his credit. But we would like to say that he's a co-founder and chief executive at Action Research and Training for Health, and member of the Policy Guidance and Review Group of the National Health Mission and Ministry of Health and Family Welfare, Government of India and Government of Rajasthan. So can I invite you, Dr. Sharad Iyengar, for your presentation, please?
Thank you, Dr. Mishra, and thank you, Dr. Shobha and Dr. Lakshmi, for giving me this opportunity to participate in this webinar. I'm going to be sharing my screen. I have a slide presentation.
Yeah, please.
Yeah, I hope it's now here.
Yeah, it is seen very well. Yes.
Thank you. And I have a somewhat weak internet connection. I might switch off my own video in that case. If I find I'm getting into difficulty, I hope that doesn't.
Yeah, that is fine. You can switch off your video. Yeah.
So essentially, as a long-acting reversible contraceptive, I just want to present our experience with the LNG IUD or the LNG IUS. We are finding that the term hormonal IUD reaches people far better, those outside clinical world. And in a sense, perhaps this is the better IUD when you compare it to the historical copper IUD, and I'll tell you why. Essentially, and a lot of this you're familiar with, we have a highly skewed method mix in India with a lot of skewed towards female sterilization, although it has reduced from 83 to 67%. And yet we know that a large proportion of women who want long-term contraception might not prefer sterilization, especially in far-flung rural areas. They're apprehensive about any surgery. And more than that, the enforced post-surgical rest for about some weeks or months, some of it is real and some of it is in their perception, affects their household routine greatly. And then if marriages break up, and there is also the system of remarriage in some tribal areas, such as where we work, they may wish to have children again, in which case sterilization is really not the best option. Copper IUD remains a bit unpopular nowadays on a large scale. There are apprehensions about pain and bleeding, and also the inevitability of women getting this feeling that whenever they go to a government hospital for a delivery, they come back with an IUD, whether they like it or not, has also contributed to this perception. Now, again, this is something you know better than I do, that the LNG IUD is a very good long-acting reversible contraception with the additional benefit of reduction of menstrual bleeding and anemia, which Dr. Lakshmi Shrikande so lucidly put out in the previous presentation. Now, we have this method since 2000, but the use has been very limited for contraception, greatly because of high cost. Mirena came in at around 7,000 rupees for the device. And then there was price control. It came down to 2,800. And now as per my knowledge, it's around 38 or 400 to 4,000 rupees a device. It is still very expensive, and the public health system has not adopted it. Our main question was, if the price was not an issue, would women adopt it in a poorer area? And so we designed an observational study to see how we could introduce it in a very low resource setting. We work in rural and tribal areas of Udaipur and Rajsamand districts of Rajasthan. Now, Rajasthan is a northwestern state. It's diamond shaped, and this is somewhere at the bottom of the diamond are these tribal dominated districts. And within that, we have an area of focus about 5 blocks. So we introduced this through primary care facilities, 3 rural and 1 urban. And essentially our intervention was one about consultation, counseling, insertion and removal services. With the LNG IUD 52 milligrams, we used Pregna International's Eloira brand. Now, we used the standard WHO resource materials and checklists to train providers. Incidentally, we have had 2 gynecologists working among the doctors, and we have very well-trained nurse midwives. These are GNM nurse midwives. And we covered counseling, screening, insertion, follow-up, managing side effects. In addition, in the field, we have about 600 community health entrepreneurs. They are like health workers, except that they make a small margin by giving out devices like condoms, oral pills. They did not provide any LNG IUD. They only promoted it and educated women and accompanied them. There's also a helpline service, and we branded this service as Mukti. Now, Mukti was meant to say that the woman could be free from both the fear of pregnancy and anemia, offered it as a long-term non-surgical hormonal contraceptive, and of course told women that it reduces menstrual bleeding and anemia. Now, really the main intervention was the price. It was offered at under 500 rupees to the general caste groups and at 300 rupees for those belonging to the tribal community who tend to be poorer. And this was an all-inclusive cost. It included consultation, screening, insertion, and the device. And we were able to keep the cost low because the manufacturer provided it at a subsidized rate, and we had a project grant to cover our other costs. We are a non-profit organization working in the community. In terms of the study, we took all precautions. We had written consent. We recorded the demographic profile, prior abortions, the phase of insertion. We advised women to follow up at 6 and 12 months, measured hemoglobin. We wish we had a better method, but we used Sali's method at 12-month follow-up. We phoned women to follow up at the community at the clinic, but if they could not come, then we had to make a home visit. So there's a small fraction of telephonic and home visit follow-ups, but the bulk of our follow-up was in the clinic. So in the follow-up questionnaire, we looked at their experience, menstrual bleeding, acceptability, satisfaction, whether they would recommend it, what did the husband say about this. If they followed up at the clinic, we did a speculum examination and also checked on hemoglobin status. So we have results covering profile, user satisfaction, removal rate, and we have looked at logistic regression analysis of what correlates with these issues. In sum, we had 1,266 women who adopted the LNG IUD over a 4-year period. We were able to follow up almost 98% of these women. The rest had untraceable addresses or migrated. And we found that urban women and those with prior contraceptive experience followed up a bit more likely, but it did not make a significant difference to the results. So these are a few charts. I'm going to take you very quickly through. I put it graphically so that it can be seen very readily. Our area is one where most residents are rural. Look at the literacy rate. Over half, 57% of the women were illiterate and the rest had primary schooling, which means we were dealing with a very, very low literacy, low educational level, poorer population. Most of the women were slightly older, 30 to 39 years is the largest age group, and the largest fraction were from scheduled tribes. We have the Bhil Gamethi tribes in this part of the country. The largest fraction had 3 or more children. So in the classic sense, they would be classified as those who needed to limit rather than space pregnancies. And clearly from their reproductive intention, you could see that 82% wish to limit births. So they were really looking not to space the next pregnancy, but not to have any more children. Contraceptive past experience was very low at 41%. And even currently at the time of insertion, a bare 20% women were using a contraceptive. So this was a first contraceptive experience for the large majority of women to whom we provided this service. If you look at the phase of insertion, you can see that the largest fraction was in the interval phase. But we have a certain number in the post-abortion phase, mainly medical abortion services, and also in the immediate postpartum period and in the late period after that. Now, we looked at the continuation status and found that 88% of women at 1 year after insertion were continuing with the method. 2% had a spontaneous expulsion and 10% got the device removed. And the reasons for removal were mainly to do with either a change in reproductive intentions, either the husband died, marriage faced difficulty, relatives in the family pressured them to have another child, or more often there were side effects. And if you look at side effects, 7.1% of all the women who adopted the LNG IUD had side effects, 71% of 10%. And of them, the two major groups were heavy or continuous bleeding and abdominal pain. Amenorrhea was an insignificant reason for removal of the LNG IUD. There was very good tolerance. And yet, if you look at this slide, a large bulk of women who had adopted it as expected and as pointed out by previous speakers had hypomenorrhea or amenorrhea. And so it shows that there was fairly high tolerance and acceptance of amenorrhea and reduced menstrual bleeding in this community. And we found clearly our regression analysis also showed that heavy menstrual bleeding and pain during periods and spotting were major correlates of removal. So in that small fraction of 7%, this was the issue. Same way, this is again regression analysis data which shows two things. One, that side effects correlate with removals, and secondly, the age group 18 to 24 had a higher removal rate. These were women with more unstable, reproductive intentions. Their lives were changing, and unlike the older women, they tended to remove it a bit more. User satisfaction extremely high. 92% were satisfied. Most of them said the expectations were equaled or exceeded, which means they found it even better than what they had expected. And the husbands were also positively oriented towards it. They were either neutral or had a good view of it. And they would, the women said they would recommend this method even to others in a similar situation. And as mentioned by Dr. Srikhande, even in this case, we found a rise in mean hemoglobin by 0.7 grams per cent in 1 year. We found that the number of normemic women went up. The ones with anemia, particularly severe and moderate anemia, reduced substantially. This study was not designed to go around measuring anemia change, but we did measure it as a secondary outcome, and it really endorses what others have been saying all along. So what do our findings mean? And I'm going to wrap up with these. One is that it is feasible to deliver the LNG IUD as an LARC in a primary care setting. Our setting has visiting doctors, gynecologists, and locally resident, well-trained nurse midwives. This is not a service, a specialized service at all. Women accept the device very well, high continuation and satisfaction rates. In our area, there are free and actually incentive-driven pubectomy, vasectomy services, and yet they paid for this device. It was not free, though nominally priced. It means that reversibility and reduction of bleeding remains a priority even among those who want to limit childbirth. 12-month continuation rate compares to international studies. And of course, there's the issue of non-contraceptive benefits, which has been spoken about. Now, the implications for the Indian family planning program are that this method, when added to the method mix, could help to reduce India's skewed family planning method mix. It would encourage more contraception among young women. It is helpful for those who want a long-term but non-surgical, non-permanent option. There is the secondary benefit of reduction in anemia, and we know from the National Family Health Survey that in India, among women of the childbearing age group, anemia levels have gone up from 53% to 57% from NFHS 4 to NFHS 5. So we have in spite of our economic boom or our resilience, we seem to see this as a major problem. There is adequate manufacturing capacity in the country. There are 3 manufacturers. 2 of them are Indian indigenous manufacturers. The skills required to remove and insert an IUD are similar to that for a cooperative. So even primary care workers like doctors and nurses could use it. It will help to reduce the unmet need, not only for spacing, but also for limiting. And in the developed countries, it is widely used. It's on the WHO essential list. And therefore, we feel that the LNG IUD should be piloted through the public health system, though this has not happened. I'm ending with this, the implications for FOGSI ICOG. This is a unique opportunity to add to the Badlav slogan that Dr. Rishikesh Pai has made. As a contraceptive, the hormonal IUD is far better than the copper T because of fewer side effects, better tolerance, and non-contraceptive use. I want to, in a way, preface my response. This is for long-acting reversible contraception. I am not referring to emergency contraceptive use. The LNG IUD is not, used for emergency contraception. But for long-term contraception, it works better. Wider use of the LNG IUD as a contraceptive will mean that it will be available far more to also treat abnormal uterine bleeding. And in large parts of small town India, the use of the LNG IUD is disappointingly low. It is the enlightened doctors and gynecologists in the larger institutions who are using it more, but this really needs to expand. My third point is the most important. The wider use of LNG IUD will lead to a major reduction in retail costs because there will be economies of scale. I know from conversations with a couple of manufacturers that the price would go down to about 1,000 or 1,500, much lower than the current level because of large scale sales. And I feel that ICOG FOGSI are uniquely positioned to advocate the LNG as the better IUD for LARC to practitioners, to the community, and to the government. Thank you very much.
Thank you, Dr. Iyengar. That indeed was a fantastic and lucid presentation. I don't see any questions in the chat box, but I have a question. Number one, congratulations for making it available around $500 your Mukti, IUD. But my question was, you did show that menorrhagia was one of the reasons for the fallout of, when they wanted it to be removed. I just wanted a further clarification. Somehow I feel we've not had too many complaints of menorrhagia. It's more a case of intermenstrual bleeding in the LNG IUs, which is normally given. So would you like to comment on that? Or?
I agree with you. One is that we found in the large majority of women,
why would it cause
overall
menorrhagia?
Quantum of bleeding went down, but there was an increased frequency. And there is a possibility that a primary care worker saw increased frequency of bleeding and number of days of bleeding as being increased bleeding, which it is not. I agree with you.
Okay.
And
Thank
the other
you so
point
much.
is, in this very small group, we had this issue, whereas in the large bulk, there was amenorrhea, which was in line
we
with
didn't have.
findings.
Okay.
I
So we wouldn't like
mention
the idea to go across.
Yes, the
that,
publication is in the journal Contraception. I forgot to mention this. I'm sorry.
Thank you so much. Over to Shobha Goody. Do you think we could go ahead with the next speaker?
I just wanted to speak a few words about Dr. Sharad Iyengar. In the past 3 years, we have had some occasion to work with him. And I must say that it is amazing that a pediatrician had this vision for reproductive health care of women. And I think it is a very sound example of what willpower can do, and how much dedication one can kind of focus, how much work is possible in rural parts of India. So this was my intention to make Dr. Iyengar speak, and I wanted to convey to the ICOG leadership also, Dr. Lakshmi, that this is what ground level work in the field of family planning can achieve. We also had a couple of online clinics when I was chairperson in rural Rajasthan. And I must say that even Dr. Iyengar's team in Earth is actually very enterprising, very dedicated, and they are in sync with the women of the of southern Rajasthan villages. And just like ASHA workers, his soldiers are also working along with women. So that is one thing about reproductive health care, that the woman really needs to be befriended, because this is a difficult decision for her. It's essentially preventive health care, and adopting a method is a really uphill task for her, because there'll be so many people telling her not to go for any method at all. And that is true in urban India also. Every day in the OPD, we come across patient level barriers, so much, and it is so difficult to overcome. It's a lot of hard work. So we really compliment you, Dr. Sharad, that you have really been able to go across these barriers and provide. It's a great work. I'm really happy to be associated with you, and we hope that in some better structured way, we can formalize. Dr. Lakshmi, if you have.
Thank you, Dr. Goody.
Yeah.
I have just noted down all the points and what we can do at national level. We will definitely consider.
Thank you. Thank you, Dr. Lakshmi.
Thank you. We look forward to more interaction, Dr. Sharad, if that is possible.
Oh, certainly. I mean, our strength is to work at the primary care level, where even doctors and gynecologists are very scarce, and I really look forward to an association with an enlightened group of gynecologists who want to see that the condition of women in very peripheral areas improves. There are various areas where we are working, and it's really of benefit to us because there's a very high degree of complementarity. We make no pretense of understanding the various things that you deal with. And yet we have our feet on the ground, and we feel that that combination can really work wonders for the sake of women at large.
Yeah, and you
Thank
do
you
have
very
a point that if cost effectiveness can be modified, then LNG IUS is a very good intrauterine contraception.
It is, I think, it's wonderful technology. It's
Yes.
needlessly very expensive.
It's
I think we got to get beyond this fact that we have a
Yeah.
sleeve on a copper IUD which liberates 20 micrograms in 24 hours, and therefore it has to be expensive. I think the cost will go down when the use is wide. Incidentally,
Use is
the
wide.
use in the country is just a few hundred thousands. It should be in the millions,
in
and then
millions.
watch the cost go down. And I think the route to that
You're
is
very
contraception.
right. Yeah. But just as an information to the listening audience, that the need for contraception is for around 400 million women
Kinti
in
going
this
to be
country.
speaker, you know, I have
So
to figure out.
that is the monumental target, women that we look at when we want to provide contraception. So with that in place, and that is a lot of food for thought for all of our colleagues. So with that in place, I will move on to yet another brilliant faculty, and I request the chairperson to introduce Dr. Manju Puri. Is it okay, Dr. Sujata? Shall I share the screen for you? Dr. Manju Puri.
Yep. Yeah.
Yeah. Yeah, just a moment. Yeah. So there you go, Dr. Sujata, please. Yeah.
Yeah. Lovely welcoming a friend, Dr. Manju Puri, who's the Director, Professor and HOD Department of OBGYN at LHMC, New Delhi. She's in subject expert committee in Central Drug Standard Control Organization, CDSCO, principal investigator of Niti Aayog, led healthcare on artificial intelligence. That sounds great. And Catalyst project. Chairperson of quality improvement of the committee of AOGODO, member national mentoring group, for Lakshya implementation. I would like to tell you, Manju, my labor room got 97% this time in Lakshya. I think it was one of the highest in the state in our hospital, and I was so happy. And then National Felicitator for Adolescent Health and Quality Programs, got a whole lot of awards. CS Don, CL Jhaveri, Suman Khair, invited speaker in the ICOG Symposium, and also the ICOG Foreign Fellowship. More than 100 publications, and 3 good books been edited by her. Over to you, Dr. Manju Puri. We'd be so glad listening to you in the next 15 minutes. Thank you. Over to you, Manju.
Sujata, we're coming to visit your labor room.
Please come. No, I must tell you, Shobha, that, you know, surprisingly, the one I'm working in now, we got 95% in the labor room, 97% in the OT, and I realized that 97% was the highest in the country this year.
And I hope PPIUCDs are getting inserted there.
Yes, but then after Manju finishes the talk, I would like to tell you, I don't know why we cannot succeed despite 13 years of, or 20 years of, 20 years of trying, you know.
Yeah.
But anyway, we'll talk about that.
So,
client experience and continuations.
Congratulations, Dr. Sujata. I hope my screen is visible and I'm audible.
Yes, it is. Please go ahead. Very clear.
So congratulations, Dr. Sujata. I'm so glad that you've scored so high in your labor room. So you're going to be one of the role models now.
Thank you.
Very interesting share by Dr. Iyengar. Thank you so much, Dr. Iyengar, for sharing that. And it makes so much meaning and it sounds so much logical for our population. So I'll be sharing a small paper which we had presented. So this is related to the client experience and continuation rates of PPIUCD. So this is the article which was published in 2022 in the International Journal of Advanced Medical Health Research. So this was a study of the client experience and continuation rate of postpartum IUCD device in semi-urban population of India. So we all know that India is the second most populous country with a high unmet need of contraception, and majority, 65% of women in India have an unmet need of contraception in the first postpartum year. And so PPIUCD was introduced in National Family Planning Program in 2009, 2010. And Dr. Shubha Goody has been doing a lot of work as far as training private practitioners is concerned. So I think it is a huge work which needs to be applauded. And despite this being a reliable, efficient, and convenient method of contraception, its uptake is dismally low. And combined IUCD, PP-IUCD uptake rate has increased from 1.5% to 2.1% of all contraceptives from NFHS 4 to NFHS 5. And the reported discontinuation rate of PP-IUCD is also high. It's approximately 25%. So we conducted the study to study the continuation rate and the reasons for discontinuation of PP-IUCD. So this was an ambispective observational analytical study, which was conducted at Lady Hardinge Medical College, New Delhi, which is a tertiary care center. And the study subjects included 180 beneficiaries of PP-IUCD with at least 6 weeks after PP-IUCD insertion. And the discontinuation rate is up till 6 months only. So this was, we tried, because they were not coming for follow-up. So initially we thought that we will contact them and find out how they are doing at 6 weeks and 6 months. The study tool was telephonic interview as per pre-designed performer as regards source of information, who had counseled them, where did they get that information from, any side effects or complications, a willingness to continue, and reasons for discontinuation. So we have an average of 1,000 to 1,200 births per month. And the baseline PP-IUCD insertion rate initially was 4.5% in 2019, which had increased to 19.2% at 3 months and further increased to 30 to 35% after 1.5 years, after we initiated a QI project, trying to figure out as to why are people not opting for PP-IUCD. And now we stand at about 20-25%. So copper T380A was inserted in 56.5% and copper T375 was inserted in 43.5%, depending upon their requirement. At the time of interview, 763 out of 880, 86.7% were continuing with the method, and the discontinuation rate was 13.3%. It is low probably because it was up till 6 months, and majority were satisfied and happy to continue it. That was 73.3%. And if you look at the demographic profile, the mean age was 26.45 years, and majority were in 20 to 30 years because we have women birthing in this age group. The mean parity was 2. Post-placental insertion was in 91.7%. Post-CS was 6.5%, and postpartum was 1.5%. That is within 48 hours after birth. And if you look at the source from where they got the information, so they got the information from healthcare professionals. So dismally, very low information was available from media and from family and friends, showing a gap as far as the advocacy of PP-IUCD is concerned. We need to have more media presence of the importance of PP-IUCD. So when you look at the problems associated with the use of PP-IUCD, most women say that is 56.7% had no complaints. I can't call it most, but well, more than 50% had no complaints. 43.3% faced some or the other problem. But of this 43.3%, only 17.3% got it removed. And this is 7.5% of all beneficiaries. And majority did not report. And we also noticed that, they got it removed outside, and majority of these patients did not report for follow-up. So maybe follow-up could have made a difference and could have, resolved their problems. I'm to say, even at the slightest problem, they would go and get it removed. Abdominal pain and menstrual irregularities were the most common side effects which were reported by the women. And I think when we talk about hormonal IUCD, both these things would be much lower with that. So if we look at this pie chart here, so it tells that 56.7% had no problem, 13.3% had menstrual disturbance, 3.5% had infection, pain abdomen, which is definitely a preventable reason. Pain abdomen was in 15%, spontaneous expulsion was in 6%, Strings found missing were in 2.9%, long thread was in 2.5%. So these were the things which were noted down. If we look at the discontinuation of PP-IUCD, discontinuation rate was 13.3%. Of these, 5.7% had spontaneous expulsion. And it was more in post-vaginal delivery insertion, that is 4.5%, and compared to post-intracesarean insertion, which was only 1.2%. Remaining 7.5% got removed for pain abdomen and menstrual irregularities. And majority discontinued it straight after the first month. Within the first month, they got it discontinued. There was no relation of discontinuation with parity. Looking at the expulsion rate, so reported rates of spontaneous expulsion vary among different studies from 5.23% to 12.12%. The rate of spontaneous expulsion is determined by factors such as method of insertion, training of the person inserting it, and timing of insertion. Expulsions are higher with insertions after vaginal delivery as compared to what they are with cesarean section, meaning thereby that we can definitely, this is one more area of gap which one can take care of by increasing the training or enhancing the training of the persons who are providing this service. I thought I'll share this interesting study, paper which I got. This is published in 2022 from a team from Bihar. So it is on facilitators and barriers in acceptance of postpartum intrauterine contraceptive devices in Bihar. So this was a study where it was done more as a study in the periphery at PHC, CHCs, sub-centers, all these areas. So 1,620 women with institutional deliveries from 9 districts in Bihar were included in this study. So out of these 1,620, 363 chose PP-IUCD. That made it an acceptance rate of 22.4%. Discontinuation rate here was 25.4%, and non-acceptance rate was 47.3%. So we saw some very interesting and different factors here which played, which were not there on our side. So husband and family disapproval. So that was a very important factor for discontinuation, which actually reflects that probably the family was not taken on board while counseling the woman. Because we have antenatal counseling in our, we start counseling right from the antenatal clinic. So maybe this factor was not so much. It is there, it is not there, it's absent, but not so much. Then health issues and side effects. Now, if this health issues, things like, these, they've just put it as health issues and side effects. So this was 66.7%. A good number was because of this. Preference of other method was 13.3%. Fear and misconception about cancer was 8.9%. Lack of awareness of the importance of this, the need to continue it is 6.7%. A desire to get pregnant was 6.7% because they probably took the continuation rates for a longer time, and religious belief. So this is how they had given. So, but if we look at the side effects, they were almost the same. So they had an expulsion rate of 8%. Menstrual disturbances in 36% and pain abdomen in 36%. So pain abdomen and menstrual disturbances stay the main important thing, which is a problem. And infections were in 18%. Sorry. So to conclude, PP-IUCD is a practical, effective, and safe method of contraception. It needs more dissemination through media by sharing its advantages and client experiences. So I think this part is something which I'm sure FOGSI can take forward. And, this is something which we really need to come up with. To improve the continuation rates, we need to focus on counseling, initiating it in the antenatal period involving the family and spouse, because that is a major issue. And we must provide them with an opportunity to ask questions and relay fears and misconceptions. Because once you counsel them, once they go back home, and then they get a feedback from others. And I think maybe we can have 2 sessions of counseling instead of 1 session, and so that they can come back. And we should give them an information sheet so that they come back and they can discuss it out in case they have any queries on that. What I feel is missing at our place is that repeat consent at the time of delivery should also be taken. So probably that is somewhere we are lacking, and that is why some people would get it removed after they go home. And to reduce spontaneous expulsion, we need to strengthen the training. And I'm sure FOGSI, Family Welfare Committee of FOGSI is looking at it. And to reduce removals for side effects, we need to increase the follow-up rates by post-insertion counseling on the importance of follow-up to mitigate concerns, if any. And of course, I would like to add, and we should think of having hormonal IUCD as an alternative, because I'm sure it is going to significantly reduce the rate of removals. Thank you so much for patient hearing.
That was very impressive.
Yeah,
Dr.
thank you,
Sujata.
Dr. Manju. Yes, lovely presentation. And I really appreciate how you could come to know the ones who actually got them removed, that 17% and so or so, because my experience is, we don't have a high insertion percentage as yours, but those who remove, we really don't get to know. Either we're not following up properly, or they go to, they go somewhere else and then get it removed there, and probably we don't get the feedback, is my personal opinion. Dr. Shobha, what do you think of it?
No, you are right, Dr. Sujata.
Yeah?
This was a telephonic interview. So there was no
Okay.
scare or anything. So they would not feel that we are going to coax them for anything. So because we telephonically contacted them, it was an intern who would build up a rapport and, then talk to them and then find out. And that is how they shared. Otherwise, they exactly do the same thing. We have placed in the hospital where they would come and get it removed. Yeah.
Okay. But it was lovely. I mean, in fact, in addition to thanking you, I should thank Dr. Lakshmi and Dr. Shobha for such a wonderful scientific schedule, Fantastic listening to all four speakers. Dr. Shobha.
Thank you so much, Sujata. Now, I need to compliment Dr. Manju for even with her such a diverse portfolio of work, she has kept a high focus on family planning, and a very productive department, always thinking of new ways of implementing. And we did get support from them for the committee as well. Thank you so much, Dr. Puri. I was really, thinking that we have similar experience, because we also conducted a multi-centric trial from Family Welfare Committee. Many of the Delhi hospitals also were involved in that. And we also had a follow-up of 6 months period. And that was actually coinciding with the post-second wave of pandemic. And many of the follow-ups were done telephonically. And as you said, we got very good feedback from women. They were very prompt about the follow-up. We had around 4.5% expulsion rate, and discontinuation in total was again around 10 to 11%. So I feel that we have similar data of outcome. But by and large, it's a very satisfying experience, because the woman goes home with a LARC method in place. I think we have served our women well if they are protected from unintended pregnancy with a LARC method before they go home, because many of them are not privileged enough to call out for help or come back when in need, and for contraception. So the contraception visit doesn't happen for them. It gets lost and they come back with a pregnancy. That is what happens most often. So I thank you for bringing that in. I think it is time to take expert comments from other chairpersons as well, and then I can go on to the last session. Yes, that will be very kind of exciting, very fast. So request all of you to be alert when that happens, because the chat box response will be expected that time. Yes, please. Any other comments on that, since it was such a wonderful presentation?
I think to make a small point, which is on this issue of consent. We need to be very careful that intrauterine contraception is, with the full knowledge of the woman and with her acceptance. Efforts to go around in any way, taking advantage of her non-comprehension or to, be a little cursory about it, then leads to a situation where women feel resentful about this thing, and then they start going to all kinds of providers for removal of the IUD, even if it is not actually necessary. I think to maintain the credibility of this method, we need to make sure that women own it when they are agreeing to insertion, rather than to treat it as some kind of normative thing, which is happening in some primary care facilities where IUDs are being inserted without proper verbal consent. And perhaps written consent of some sort should be considered as a way of keeping the discipline among providers.
Yeah, I think that is a point well brought out, because per se, Government of India does not acknowledge the mandatory inclusion of consent for family planning procedures. So it is only a checklist which has to be kind of covered before doing a PPI-UCD insertion, either post-delivery or intracesarean. So if that checklist is done and there is a particular seal, I believe, for in the public health system, which we all have seen, I think, and the woman has clearly kind of indicated which method she has chosen. And if PPI-UCD is chosen, then that is taken as consent. But of course, we can always reconfirm, as Dr. Puri also mentioned. So consent, yes, from the hospital and provider point of view, it is mandatory, but the Government of India does not put any, mandatory inclusion of consent in service provision. Now, having said that, when we talk about consent in family planning, consent and counseling go together. Consent and counseling go together. And I find myself agreeing so much with Dr. Puri that we need to have more than one session. I would say that every opportunity we must go on talking, because I think it's the provider's conviction and the honest advice which actually percolates into their conscience. Otherwise, they're simply too much against the device to begin with. To begin with itself, they don't like contraception, and they don't like the idea of IUCD being inserted in a parturient uterus. So I think that is a barrier we need to cross. And I think we have to convince our own providers in FOGSI, in ICOG, that PPI-UCD is a very scientific tool. It is a very scientific method, because many are not convinced about that. So this paper and these sessions today were designed to inform everybody that intrauterine contraception is highly scientific in every form that it has been spoken about till now. And everything that we spoke about today is actually there in the Ministry of Health website also, completely endorsed by the Government of India. So any more comments by Dr. Lakshmi, and Dr. Parag has joined us back. Thank you so much, Parag, for coming back from your emergency.
Waiting for your case discussions. So you can start.
Parag, shall I go ahead, or you are going to tell us anything? You are muted right now. Okay.
पराग को क्यों अनम्यूट नहीं कर रहे भैया? उसको अनम्यूट कर कोमल ना.
Yeah, it's done. Yeah, thank you. First of all, I must compliment Dr. Manju Puri for a wonderful presentation. Manju, whenever we listen to your presentation, it's a great learning experience, because your slides have very clear-cut thoughts and very simple but doable messages. So thank you for a wonderful presentation. And Shobha, I totally agree with you. Even in private practice, whenever we counsel women for PPIUD, we usually start counseling them, say, around 34 weeks. And every week when we meet them, we talk about it. We encourage them to ask questions, so that and then we find that their acceptance is much better. So this is something which not only in the public sector, but even in the private sector, if we all decide to adopt, I think it should do wonders for prevention of unwanted pregnancies. Thank you.
Yeah, thank you so much, Parag. And I will now share the screen to introduce the young faculty amongst us. One of my Sankalp champs, who has really worked very assiduously for the committee, Dr. Chetna Ramani. She is a consultant OBG at Ramakrishna Care Hospital, Raipur, Chhattisgarh, also at Nest Mothers Clinic. And she is interested in contraception along with adolescent gynecology and critical obstetrics. And she is a life member of our organization. So thank you, Chetna, for joining and helping me with the quiz. So I will stop sharing, and you can you can start sharing your screen. Yeah. Yeah, please go ahead.
Good evening, everyone. Am I audible?
Yeah, you are audible.
Okay.
Please share your
Many
screen.
thanks to the organizers and many thanks, madam, for your kind words. And here we go with the quiz now.
Share the screen, please. So we are presenting to you simple case scenarios. There are only 4 in number, and we shall be going very quick, and we'll complete it within 15 minutes or so. So we request you all to be very active on the chat box, and we can have some interaction there. Thank you. Can you share the screen?
Okay, I'm trying to. It's on
Yeah,
the desktop. So
Yeah, is it open? Your presentation is open on the screen?
it was, I just 1 second.
Yeah. You can see the share screen icon below, green one.
Is it visible, madam?
Not yet, not yet. Share screen
Because
करिए थोड़ा.
it is there on my desktop screen.
नहीं, आप share screen करिए from the main. Please share screen करिए from the main. Okay. Are you able to share?
No, madam, because
Is there any network issue?
no, nothing. I just I can do it on. Actually, I sent it to you as well. I just,
Achha, okay. Whatever I have on my desktop, shall I share that then?
okay, few changes. No, latest I have sent you. But 1 second, just.
Okay. Let me also see whether. Be a little quick because we should not be losing interest of people.
Madam, can you just see in your mailbox?
I am looking, and I will see. So, I'm just trying to see. I'm sorry about this. Okay, I have got your presentation. I will be downloading it, and let me hope to.
This is actually the old system.
No problem. Let me just try to save it on the desktop. If I'm able to save it quickly and open it, it will be done. Yeah. Okay, let me just open it. Then I'll be sharing now. Yeah. So I'll share my screen now. Is it seen?
Yes, ma'am.
It is seen. Okay. So here we go
Yeah.
with the quiz. Okay. So you can go ahead. Please call out. Yes.
Am I audible?
Yes, you are audible.
Yeah, yeah. Okay. So I'm very sorry for that. Yeah. So Mrs. X, she calls to get emergency contraception, and the condom broke last night. Hello. Hello.
Unmute. Okay, hello.
Hello, yeah.
Huh. Can you call out this slide? Hello, Chetna,
Yes,
any
I'm
problem?
doing, madam. Madam, suddenly there is some problem with the system.
With my system?
With my system.
Okay,
Am I
can you
audible,
speak
madam?
now? Yeah, you're audible.
Yeah.
Please go ahead.
Yeah. So Mrs. X, she calls to get emergency contraception, and the condom broke last night. Her last period was 12 days ago with regular cycles, and she is not on any medication, and her BMI is 32. So I told her to take one LNG emergency contraception now and advised her to attend the facility for postcoital IUCD. So the question is, why did I counsel her for an additional method? Next slide, please. So here comes the reason that she is in the peri-ovulatory phase. She has high BMI. BMI is 32, as we said. And the efficacy of copper IUCD is unaffected by BMI.
So here I think there is a fine tuning for emergency contraception because the LNG IUS can fail at times, right, Chetna? So
Yes,
especially in women with high BMI. Huh? So that is the reason you have called her for an additional method. Now you can take this.
LNG EC, yes, madam.
Yeah.
Yeah, and it can work as an ongoing contraception as well.
Can you see my slide now? This slide on
Yes, ma'am.
FSRH?
Yes, ma'am.
Yeah.
So we have the evidence by FSRH as well that the available evidence suggests that the effectiveness is not affected of effectiveness of copper IUCD by high weight or BMI, and that the 1.5 mg LNG, what we suggested her, it appears to be less effective with BMI more than 26, in fact. Yeah. And the ulipristal acetate, it may be less effective if the BMI is more than 30. And therefore, the recommendations go like, we have to inform her about this, and that the copper IUCD is the most effective method. And because her BMI is more than 26, so it may reduce the effectiveness of the LNG ECV suggested.
Okay, so that is the message here, that there is a lot of nuancing in prescription of emergency contraception as well. And we need to always judge the, the efficacy, possible failure of any method that we prescribe. And that is where copper IUCD scores over oral emergency contraceptives. Can you take this case now, Chetna?
Yes, ma'am. So another one, Mrs. W, she's para 2, living to 39 years old, and she has completed family, but not tubectomized. And she is a diagnosed case of mild to moderate endometriosis. And she's on the low-dose combined oral pills for the same, for pain relief. She has been comfortable with this therapy, and as it is also providing her effective contraception. She is diagnosed recently now to be hypertensive. So after adequate consult with physician and antihypertensive medication, she comes for a review of medication, where I offer her the basket of choice, and she picks up LNG intrauterine system once she knows the benefits on her disease.
So can we have the audience to say, opine on this and tell us whether this was a right decision, or would they have it any other way, or what do they think that, how much benefit she will have, and also how to counsel. So, Chetna, can you go ahead?
Yeah. So how to counsel about the use of LNG IUS in this patient? Next.
You have next. Okay, that's good. Yeah.
So we all know that LNG, we have been talking about this LNG IUS, that it's a T-shaped device containing LNG 52 milligram, where it releases 20 microgram per day, which reduces to approximately 10 microgram per day after 5 years. So particularly in this patient, apart from, it reduces primary dysmenorrhea, but here it reduces pain associated with endometriosis and adenomyosis as well. At the same time, it reduces heavy menstrual bleeding and thus improving serum ferritin levels. Thereby, it prevents iron deficiency anemia. And all this leads to improved quality of life.
And also, it's an excellent contraceptive, isn't it?
Yeah, for that only we are telling that.
Yeah, correct. Yeah.
Yes.
And this?
And pertaining to the newly developed hypertension, so data so far generally suggests that there is little or no risk of VTE, venous thromboembolism, and myocardial infarction. And we have evidence for this in FSRH, where they have studied. And apart from that, other non-contraceptive benefits also, like prevention from acute episodes of PID. And because it works as contraception and it lowers the pregnancy rate generally, so it lowers the rate of ectopic pregnancy as well. And it can, it does not have any adverse effects on lipid profile or cardiovascular profile. So these are the additional benefits in these cases.
Yeah. Yeah, Chetna, also, I think this is very, very kind of relevant here, because we all know that tubal disease, if it is there in endometriosis or endometriosis related pelvic problems, there can be higher incidence of ectopic pregnancy in them if they become pregnant. So that is one of the reasons why this method is very suitable for a woman with this kind of profile. This is my question to the audience, and I will expect some answers on this, please. Whether we can offer IUCD to adolescent girls and nulliparous women and unmarried women. So can I have some responses in the chat box? I'm eagerly waiting for people to respond in the chat box. Yeah. So do you think that we can increase the scope of service of IUCD? Thank you, Dr. Alka Kute, for giving that response. She says yes, and I wholeheartedly agree with her. Adolescent girls, as in more than 18 years, of course, because of the FOGSI Act being so strongly implemented in our country. And in nulliparous women and unmarried women, it is an excellent method. This is a 19-year-old techie and unmarried, and of course, not because she's a techie, but she does have more boyfriends, rapidly changing ones, and her stress of work, also gives her socially insecure relationships. So to this girl, what can we offer? Definitely a basket of choice. So can we offer IUCD? Chetna, do you wish to say anything here? This
Yes,
slide?
madam.
Yeah. Yes,
she's
please.
sexually active, and adolescents, young population who are sexually active, definitely once they get pregnant, they will go for termination of pregnancy. So it's all the more important that we take care of both the things, pregnancy prevention as well as prevention from sexually transmitted infections. So I will definitely
yes
say
for
yes.
all methods, and here we have this dual
Including
protection. What is that concept? Dual protection concept, very elegantly given by USAID as a technical guidance in 2005, but I think it's still it still applies even today. And I'm sure all the faculty and delegates will agree with me that what we think of dual protection is as condoms primarily, along with a steady method. And in that primary method of pregnancy prevention, intrauterine device also fits in. So it can be pill, IUCD, or emergency family planning, or injectables, etc., along with condoms. Suppose the woman is unable, the girl, because we are also talking about relatively younger girls, the youth population, which are such a complex, psychology, that we are unable to reach out to them. They may not accept any of these methods. And then we are at a loss, but not to despair. We can always tell them condoms as the primary method of pregnancy and STD prevention, and tell them that emergency contraception should stand by, and they should be thoroughly advised about emergency contraceptive. And if ever they agree for copper IUD as an emergency contraceptive, they should be given that. So can anybody in the audience tell us what is the other name given for interval IUCD? I can see some chat responses. So actually, Dr. Manisha Dhanokar has given very good inputs that there is threadless IUCD is available. I agree with you, Manisha. And Ashwini, of course, says frameless IUDs will be better. I hope they are all easily accessible to our practitioners. Thank you for those inputs, Manisha and Ashwini, and also Alka. So can I have some responses on this? What is the other name for interval IUCD? So Chetna, do you want to say? Yeah.
Yes, ma'am. Yeah, it's like it's anytime method. So anytime means anytime in menstrual cycle when we are reasonably certain that she is not pregnant, and we call it quick start contraception. And if they are switching from another method which they have been consistently using, so again immediate insertion we can do,
It's
or
immediately
post
effective
abortion
also.
or post delivery also. Anytime 6 weeks after delivery when we are sure that she is not pregnant, or anytime after 12 days of completion of an abortion.
So this is a
it
standard
is
question.
literally like we can use any time, but yes, definitely this method is underutilized.
Yeah, so that also quite a few in the audience agree to that. Dr. Kuthe has already. Do you want to do this, Chetna? Sorry, I should go
Yes.
ahead. So that is amongst the
So,
last slides that we have about the myths and misconceptions. Yes, please.
yeah, so IUCDs do not cause PID. At insertion, if there is undiagnosed cervicitis, it may result in PID. So quickly, if everyone can write whether it's true or false.
Okay. Yeah, true. Manisha has said true. Go on. Alka has said yes. I would like to see more responses. Yes. Next.
So if there is undiagnosed disease, that's a different thing, but generally per se, they do not cause PID. And this is one of the biggest myths here. So, and they do not increase the risk of contracting sexually transmitted infections, including HIV. True, false.
Dr. Sharind Iyengar says true. It does
True.
not increase. Manisha says true. Does not increase. Thank you so much. Yes, go on.
So
I think
they
we'll
do not
skip
make
the next one. For this is not for consultants. I think it is for patients. Go on to the one with miscarriage. And suppose the woman
they do
falls
not
pregnant with IUCD in place, and we manage the early pregnancy by removal of IUCD. Will this woman suffer with higher risk of miscarriage or with birth defects? So, okay. So what should we do here? What happens? Yes, true, it does not increase the risk of miscarriage. Leaving it there might increase the risk of miscarriage or preterm birth or sepsis, but removing per se will it is going to do more benefit than harm. So definitely, if the string is accessible, please remove the thread in case there is pregnancy along with IUCD. And birth defects, definitely there are no birth defects. Okay, they do not cause cancer, of course. Do not move to other organs. I would like a response on this question. Yes. Does copper IUCD migrate? Do not move. True or false? This is also important for the provider, because this is something that everybody will say that it moves, so I don't want it. So Dr. Alka Kute says true, it does not move to other organs. Then why do we find IUCD in the bowel, or we find it in the omentum or below the liver, etc.? So once I found it in the sigmoid colon. So it is a faulty insertion technique and inability to judge the uterocervical length, and an initial impact into the uterine wall by one of the limbs of IUCD, and with subsequent, some uterine spasms during menstruation, it goes more and more deeper, and finally it goes out. So even if there is not a complete perforation at insertion, transmigration can be because of an initial faulty placement where the IUCD gets into the myometrium of the uterus at the time of insertion. Then does it interfere with sex? Does it interfere with sex? What should we tell our women? Because sometimes we do have complaints regarding that from the partner. So how much importance to give? Does it really interfere with sex? I think there is a strong message to say that it absolutely does not create any dyspareunia, either for the man or the woman. And the threads usually soften in the cervical mucus and they lie on the side. In fact, there are so many instances when we struggle to identify the thread inside the mucus which is there. So it does not cause any problem. I'm so sorry. I don't know why this is playing around. I'll just go to the last slide. The image did not come. Reducing the risk of ectopic, we all agree to it. So I think this did not come. Okay, Chetna, I don't know what was there. Big thank you. Okay, thank you so much.
That was the health comes first. Yeah.
Okay, okay. Thank you so much. So Sujata has told me that was wonderful. I was actually feeling juvenile doing this, but the people whom I bank on for quiz, I did not find today. They are all very busy. So I thought that why not I join Chetna and finish this, because, we have kept that as one of our attractions, and I did not want to forego that. Thank you very much, everyone, for your patience.
And actually, the quiz gave a strong message, madam.
Yeah.
By putting these do nots and they do not.
Yeah, correct.
So it's all about positive about IUCDs.
Thanks so much for your help, Chetna, in that. It may be simple, but it is highly relevant. Okay. So with that, we come to the end of the session today. And I would like Dr. Lakshmi to conclude, and then I'll give my thanks. Yes.
Madam, I have a question.
Yes, please.
Okay. I had one of the patients who conceived with IUCD, which was low placed, and her pregnancy test was positive. And on ultrasound, it was just the start, so it was just a thickened endometrium. And then she was insisting to give a medical termination. So she was insisting on removing the IUCD. So what should be? I mean, shall we remove? Anyway, she was going for termination. So I asked her to wait for a couple of days so that we should be able to see the sac properly and then go ahead with the decision. So,
Dr. Alka, would you like to unmute and respond? Dr. Alka, she has given some response. Dr. Alka Kute.
Hello, good evening, madam.
Hello, Alka. Good evening.
Hi, excellent, same as always. Ma'am, this is I think the UPT is positive, pregnancy test is positive, but there is no sonographically detected sac yet. So we call it as pregnancy of unknown location. Exactly. So in case the endometrium is thickened, we can give her follow-up. If she's persistent for MTP, we can go for suction or early methods of MTP, like medical methods of MTP. And we can remove IUCD because pregnancy test is positive, with detectable gestational sac. But we can wait till this sac is there because we
Yes.
call it as pregnancy of unknown location.
Yes.
Since endometrium is just thickened, but pregnancy test is positive. I think so.
Yeah, very correctly said. I would like
But-
a serum beta HCG at this point, and I would
Yeah.
like to remove off the copper IUCD, and I would like to call her, depending on the beta HCG, if it is below the window, of
Madam,
demarcation.
pregnancy test positive. I mean, not only UPT, beta HCG as well, because UPT we know it's not reliable method of pregnancy. Means,
We
yeah.
consider it reliable because the recently available tests are quite sensitive. No, they're 50
But
MIU
still,
per
beta
ml.
HCG will be more.
Beta
Beta
HCG
HCG will be
will
more
be good.
diagnostic.
If
Yeah.
it is below the
Madam,
demarcation
she
level for a
was
sac,
previous,
we can wait till the
Yeah.
sac is
she was
removed
previous
and
to
then we can-
cesareans.
Yeah.
Madam, she was previous to cesareans, and in fact, I thought that it is halfway out. So I tried pulling it, but it was not because the os was very tight. So I told her in that case, it might even, you can start bleeding unnecessarily. Let's first diagnose it and then. So how about going for medical MTP without removing it, madam?
Yeah, it is possible. It is not if the woman knows that the IUCD will come out at the time of miscarriage, it is well and good. There is no harm. in
Previous
that.
to scars.
Because
We can wait for few more days.
Yes,
we can
we
wait
can
for
wait.
few more days.
We can wait. And
But
then,
will the IUCD cause problem in dilating the cervix and
no,
in
no,
previous
I
to-
don't think it will cause. It at the most it might require a technique to remove it if it does not come out with the sac. Maybe it will require hysteroscopy at a little later date, but not immediately. First, we have to
Yes.
deal with the situation. We have to
I
see
thought
where
not
the
to meddle,
pregnancy
yeah.
is and then manage. Yeah, but that was a good case you brought in. I can see my friend Nibha
Recently,
there, and I can see so many people actually. Thank you so much, everyone, for joining. And now, Dr. Lakshmi's words, please, before we say goodbye.
You can also conclude. I just want to say that it was a great learning platform and good discussions with practical take-home messages by all the speakers, and the points brought out by Dr. Sharad. Shobha, we will definitely discuss and we will deliberate on it, what we can do at FOGSI ICOG level. And that,
Madam, one more thing I wanted to ask.
Yeah.
Because I had couple of expulsions, Mirena expulsions because of adenomyosis and a little, longer uterus, more than 10 centimeter, 10.5 centimeter. So I heard that people do ultrasound guided insertions as well. So any
Not
comments on that?
greatly additive to the accuracy. If it is possible to do a sounding, I think an outpatient insertion is well. It is only when force is required to insert that we take the help of ultrasound or we use dilatation methods, etc. But otherwise, it is possible to insert in the OPD. If you find expulsions are happening, most probably, we are not judging the uterine cavity enough. If it's a very big cavity, then expulsions are likely. Or if the woman has very severe dysmenorrhea, she is having spasmodic dysmenorrhea for some reason, maybe. So expulsions have been encountered with disease uteri and LNG-IUS, and it should be factorized into the counseling that your chances of expulsion of the device are higher than other women. And she needs to accept it along with that caveat. And then I think it is okay to accept it, and it works more often than it gets expelled. I must say that. It stays
In fact,
in
I have
place.
seen, madam, for those we put for AUBs, they are more likely to have expulsions than those who are
Diseased
put for.
uteri, yes. If there are big uteri, if there are fibroids, even not distorting the cavity, adenomyomas not distorting the cavity, so you choose for an intrauterine device. But then if the uterus is very vascular and causing a lot of pain, it does go into spasms during the menstruation, and that can lead to a little higher chance of expulsion. But as I said, that goes with the counseling, and then the patient will have to accept that expulsion has happened and it is part of the problem, and not the device is not the problem. It is the underlying uterine disease which is the problem, and that will solve the day, I think. And you can continue with something else, or you can wait for some more time and then try a reinsertion. Yeah.
So we are coming back again and again to only two C's when it comes to IUCD, and that is consent and counseling, which Dr.
counseling.
Shobha has rightly said, it goes hand in hand. And of course, you have to rule out the contraindications. You have to counsel definitely, and we will definitely work on the consent form, Dr. Shobha, for IUCD from our ICOG side. And yes, you have to first see whether it is suitable for that particular woman, because that you only can decide as a care provider, because she is dependent on you. Whatever advice you will be giving, she will be giving a thought to that advice. So as a care provider, you first should know that LNG, whatever IUCD is suitable for this particular woman. Counsel. I will say take written consent, and many of the problems will be solved. Like somebody was asking what to do for breakthrough bleeding. Once you have counseled her, then she takes it as a minor side effect of that IUD, and she accepts it. But if you have not counseled her, she will definitely panic the moment she sees the breakthrough bleeding, because she will say, my God, I have gone to this doctor for my bleeding problems, and what is this? I am having more problems. So, I mean, throughout this whole 2 hours, I think the take home message is first find out whether this is suitable for that lady, take consent, counsel, and follow up is also very, very important. Don't forget that these devices are 5 years, 7 years. Many patients I know, they do get lost to follow up, but it is our responsibility to make sure and emphasize the importance of follow up to this woman. So I think it was a great deliberation and good take home messages, Dr. Shubha, on the IUCDs for everyone.
Dr. Lakshmi, I just wanted to add one thing. India's population is more than all of Africa put together. There are 5 or 6 countries in Africa where the hormonal IUD is being introduced with good results. In India right now, the focus of the government is on implants and on the subcutaneous DMT, which are good in themselves. And I think right now there is nobody speaking up for this or using this more. There seems to be this mental block that it is a very expensive method. The cost is a function of the usage. And in a country of India's size, the cost can go down very substantially. I think, therefore, in the private sector, there's no better body than FOGSI to go around taking this up and to see whether large hospitals can introduce it. I believe that the Indian manufacturers would be willing to provide it at a special rate so that the market expands.
It is available. When LNG IUS was first introduced, the cost was really very high. But now the Indian manufacturers are there, and it is just as 1/3, 1/4 rate of the which was available 8 to 10 years back. And I'm sure it will again go down as more and more manufacturers will come up and they will start promoting this LNG IUS.
The competitiveness has to be kept up. So they will reduce prices.
Piloting it in some large hospitals where there is scope to provide women with this option would be a way to go, and FOGSI could spearhead that.
Sure, your points are well taken.
That's a good suggestion. Yes,
definitely
must
deliberate on it. Yeah.
Yes, thank you so much. And Dr. Lakshmi, we also kind of need to again request you that whether we can have a campus dedicated to family planning, where we can put all these, whatever we do, lectures, we can structure them well as very good reading material, and we can use them there. Thank you. Yeah, so thanks a lot for that. And with that, I thank again the FOGSI President, Dr. Pai, and Dr. Lakshmi for giving us this opportunity. I thank the chairpersons, Anuradha Madam, Dr. Ashish, Dr. Sujata for chairing the session and bringing out all the wonderful, positive points in the presentations, and conducting the interactions so well. I thank Dr. Sharada Iyengar, Dr. Pushpa Jungare, and of course, Dr. Lakshmi for that brilliant presentation, and Dr. Manju Puri for bringing home the fact that we can do the best research in our medical colleges. Dr. Sharad, your work is extremely laudable, and we are actually inspired by your reach to the periphery, which FOGSI finds it so hard to achieve sometimes. And also, I thank Chetna for giving me company on the quiz. Thank you, Chetna. and the audience for taking their time out. I think it's time for consultation for all of you, but you have stuck on with us. Thank you so much. And the ICOG office team, they put in so much of effort for each and every session, which is happening almost every day. So thank you so much. And Nilima and your team, thank you very much. Komal, etc. And also Jignesh for the help for the flyer. That was really wonderful, and the excellent platform that you gave us. So thank you, everyone. Thanks a lot. Very good evening to all of you.
Yeah, Komal, you can stop recording. Yeah.
Yes, ma'am.
See you all next month
Thank you very much.
with another great